What I was going to take you guys through today was hypothyroidism and also hyperthyroidism, but we'll start with hypothyroidism. I hope you guys have covered, I hope you guys have read a bit on this, on Davidson's. It's more or less like a really short topic. Yeah, so let's go. Let's proceed. So we're going to go through the definition, the etiology, the pathophysiology, the clinical features, then diagnostics, management. Of course, there'd be differentials. Then I would give you an example of a history and then a Viva question just to test whether you've been listening. Yeah, like the Viva question will just be more or less all of this. Not so much on management, but definitely a lot more on this. Okay, so let's begin. So when we think of hypothyroidism, we are talking about a condition where the thyroid gland is underactive, as opposed to hyperthyroidism, where the gland is hyperactive. Okay, so what happens when the thyroid gland is underactive? This results in a deficiency of the thyroid hormones such as T3, the triiodothyronine, and thyroxine, which is T4. Could someone tell me which of the two is uh, most available in the body between T3 and T4?
T4.
T4. Okay. There's a certain ratio to it, and I think it's 90 to 10, 90 to 10%, I guess. hmm But yeah, T4 is the one that's actually why in diagnostics you mainly test for T4 levels. Okay. Uh, Now, when we're talking about hypothyroidism, it can be congenital or acquired, meaning that it can be a condition that you're born with or something that you get as you progress in life. And then the most common forms are primary hypothyroidism, there's secondary hypothyroidism, then there's tertiary hypothyroidism. I'll come to explain all of this later on, but they're generally easy things to get. And the hypothyroidism is more prevalent in women with a ratio of 1 to 4, male to female. Male to female ratio is 1 to 4. So you can already see that it affects women a lot more than men, 4 times higher than men. Okay, so let's go to the etiology. Now, why is it called a primary, or why is it called a secondary, or why is it called a tertiary condition? So primary just basically means that it affects that particular organ, which is the thyroid. So in this case, insufficient thyroid hormone production. So that means there's a problem with the thyroid, which can give rise to conditions such as Hashimoto thyroiditis, which is the most common, form of hypothyroidism in areas with proper iodine intake. Like, if this is not an issue, then we consider this one a lot more. So in areas with sufficient iodine intake, and you still get hypothyroidism, we normally think maybe Hashimoto's because it's the most common one. Then we come to postpartum thyroiditis. As the name suggests, that usually means after pregnancy, like 12 months postpartum. Then there's the equine thyroiditis, which is usually a subacute granulomatous thyroiditis, and it's normally occurs after you get a flu. So in case you have a flu, then you get hypothyroidism, then we assume that it might be this. Okay, then iatrogenic. You can get it because of radioiodine therapy. You can get it because of a surgery that removed part of your thyroid or all of your thyroid. Or basically, you can also get it as a side effect of anti anti-thyroid medication. Uh, in this case, you guys remember your pharmacology? Like, what sort of anti-thyroid medications do you get? Just one would be enough to continue.
Levothyroxine.
Okay. All right. And then now we come to insufficient intake of iodine. Now, in insufficient intake of iodine, now this is the most common, as in most common cause of hypothyroidism worldwide. Not just in iodine sufficient regions, but worldwide. Because it's mainly when we think hypothyroidism, normally people think nutritional, then they think, oh wait, you've been taking iodine. Okay, fine. Maybe it's Hashimoto. Okay, oh, you had radiation on your neck. Oh, could be that. Or you had surgery. Okay, could be. Then they come. So the order is insufficient intake, most common worldwide. Then most common in areas with sufficient intake of iodine. Then you can think all of these. The rest. The other causes, I haven't mentioned them. You should go read on this later on, or if you have, you know them. Once again, I would urge you to read on them. And then secondary hypothyroidism would be the would be an issue dealing with the pituitary gland. Okay, so there's this axis. It's called the hypothalamic pituitary thyroid axis. So when we talk about primary, it deals with the thyroid. Then secondary, it deals with the pituitary. Then tertiary, it's just mainly hypothalamus. So along that axis, the farther you go up the chain, the more uh, the more you know if it's primary or secondary or tertiary. Yeah, that's the word I was looking for. Okay, so in secondary, we normally have pituitary disorders like pituitary adenoma that can lead to thyroid stimulating hormone deficiency. TSH is thyroid stimulating hormone. Then we come to tertiary hypothyroidism, which is mainly hypothalamic in origin. And TRH is just simply thyrotropin releasing hormone. Okay, so it's TRH is the one that stimulates. Uh, okay, TRH is released by the hypothalamus to stimulate the release of uh, the thyroid stimulating hormone from the anterior lobe of the pituitary gland, which then activates the thyroid gland to release the said hormones T3 and T4. That's just the chain of how it goes. I'll explain it in. Okay, you come to see it in the next slide right there. Okay. So pathophysiology. The primary, secondary, and tertiary, how they normally occur and how they present with. Uh, Once again, this is the axis, the hypothalamus, anterior pituitary, and the thyroid. These are the organs that are involved, and these are the hormones that you can see here. There's also TSH beta, but then we don't normally look at this a lot. We look at the chain going down. Okay, so in primary, what do we see? There is usually a thyroid disorder where your T3 and T4 are low. Then your TSH has to be compensated as a compensatory rise. As you can see here, if this goes down, then this one has to come a lot. Then secondary hypothyroidism, this is mainly a pituitary gland disorder. And this is the anterior pituitary gland. So in this case, TSH levels shoot downwards. And then what happens? If this one shoots downwards, then of course the thyroid is affected. And if the thyroid is affected, you do not have T3, T4 because TSH is the one that stimulates the thyroid gland to release these hormones. So if TSH is low, then there's low activation. And if there's low activation, then the hormones here are produced at both low in levels. Okay. So now we come to the the origin of all this. So if there's something wrong with the hypothalamus, that means your TRH levels will shoot downwards. And then if the TRH is down, there's no activation of the anterior pituitary gland to secrete TSH. So the TSH levels will also go down. And if the TSH levels will go down, then they don't stimulate the thyroid to produce T24. So what happens? Underactive thyroid, meaning that T3, T4 also shoot downwards. Sounds pretty easy, yeah? Okay. So let's move on to clinical features. I hope I'm not taking you too fast. You guys have understood all this so far. Like, a yes or a no or a question where I've lost you.
We have understood.
Okay, nice. Clinical features. If I appear as if I'm rushing, please stop me. I want to see how far we can go if we can reach hyperthyroidism as well. So, clinical features. Usually, when someone comes to you with hypothyroidism, they usually present with symptoms that are related to either a decreased metabolic rate or myxedema or just something that will tell you that, oh, okay, fine, maybe the symptoms, the psychiatric conditions that might present similarly to depression. They might also present with something similar to depression, which you'll see. So when you start with the symptoms are related to decreased metabolic rate. So we're looking at fatigue, decreased physical activity, is the cold intolerance, decreased sweating, the hair loss, namely at the outer third of your eyebrows. So you'll start seeing hair falling off, and then you'll be like, wow, how did this happen? Yeah. Then you also have brittle nails, cold, dry skin, as opposed to hyperthyroidism, where it will be warm, sweaty skin, possibly even clammy. Then you'd have weight gain. Remember what we covered in endocrinology, the history part. So you'd have weight gain despite poor appetite. Like you're not eating, but you still eat. Yeah. And then you'll have constipation, bradycardia, which is the slowing the heart rate of less than 60 beats per minute in adults. For children, it's a whole other thing. So I won't get into that right now. Then you'd have the myopathy, myalgia, stiffness, cramps, and then you'd have something called a Waltman sign. That's something that you'll find in your systemic exam. So what you'll do, that's usually like when you're doing a CNS exam, and someone took you through that, either Nate or Sean, uh, you will have something like a delayed relaxation of the deep tendon reflexes. The deep tendon reflexes are simply these the biceps, the triceps, those ones, those tendons, the reflexes. So they'll usually be a bit slow, where you'd think it will be fast. But you can also see it in people with advanced age, people above their 60s. You can also see it in people with pregnancy and diabetes. So kind of have to also take note. Wolfman sign is not a diagnostic sign. You'll have to also check if your patient is old or if they're pregnant or if they have diabetes. Then you can say, oh, okay, fine. Yeah. Then you can also have entrapment syndrome, like carpal tunnel. Another thing for carpal tunnel syndrome, you can normally see them in people who have office lifestyles. Those guys who like typing. Okay, not like typing, more like their job, or they use their fingers a lot. Like pianists, secretaries, anyone who's using a keyboard for extended periods of time, you can get entrapment syndrome like carpal tunnel. That's a given. Okay, so we come to symptoms related to generalized myxedema. So this is just a collection of fluid in various tissues. So your face will look a bit puffy, and they call it a dewy skin texture. perfect or perfect appearance. A rude way to a rude way to say this is that they look like a toad. And normally, if you say toad-like appearance, you get 0 marks. Probably the doctor will throw you out. So it's not a nice thing to say. Even you wouldn't like to be called a toad. We usually just say a puffy appearance with doughy skin texture. Uh, then you can also get myxedematous heart disease, such as dilated cardiomyopathy, bradycardia, which was mentioned before, and difficulty in breathing. Now, in this case, dilated cardiomyopathy would just mean that your ventricles, either your left ventricle or right, or even both, have been dilated a bit too much, and they have impaired contraction, leading to heart failure. So when they lead to heart failure, okay, I really shouldn't be saying this, but when it leads to heart failure, you'll also get edema. Now, this is where the edema comes in. You'll have the edema here, but then usually it's bipedal edema. Then you'd have congestion and whatnot, all those things. But for now, someone else will take you through. Yes. Okay. Usually, dilated cardiomyopathy is not just related to hypothyroidism, it's also related to myocarditis, ischemic heart disease. You'll also have people with pregnancy also getting this because obviously, when you're pregnant, you're dealing with survival of two beings, you as a mother and then the kid. So the heart will do double work, which is why you can get dilated cardiomyopathy in pregnancy. Also, if you are a heavy alcoholic, people who take alcohol here, please take note. Dilated cardiomyopathy is a risk, is a symptom that you're at risk of getting if you take it for a long time and in a large volume. Okay, but more on that later on. I am not here to discuss about alcoholism. There's also a hoarse voice, difficulty articulating words, and then there's a coma. A coma is a complication that I will explain later on. I'll put it there as a complication. You'll just see it. You'd also have symptoms of hyperprolactinemia. When we say prolactinemia, it just means that your prolactin levels are through the roof, like they're too high. So what happens when you get hyperprolactinemia? You get an abnormal menstrual cycle if you're a lady. That means that you get a secondary amenorrhea or menorrhagia, uh, menorrhagia, and then you'd also have galactorrhea. If you're a man, you'd get decreased libido, like ED. You'd have delayed ejaculation, and then infertility in men. And then further on, this is where now you'll see something like psychiatric, or just basically something else. You'd have impaired cognition. So your concentration and your memory would be in the dumps, to say the least. And then you'd feel like you want to sleep a lot more than you should. So somnolence. Yeah. You'd feel like you should sleep a lot more than you should. And then depression. Once again, the psychiatric form of depression, not the social media aspect, the psychiatric one. You can get depression, which is why a very important differential here would be depression. But you also get hypertension. Believe it or not, hypertension is, in this case, it's secondary hypertension. An important cause of hypertension, secondary hypertension, is primary hypothyroidism. Forget the others like secondary, tertiary. This one would be primary hypothyroidism that can lead to hypertension. Other causes, other endocrine causes of hypertension would be pheochromocytoma, Cushing's, Conn's syndrome. Yeah, we'll come to, okay, someone will take you through hypertension as a topic later on, or probably you already have. Did anyone take you through hypertension? Hello?
No, we haven't yet gone through hypertension.
Okay. Um, hmm. So there's usually like an acronym for hypertension. I'll just write it down for you. Recent. You'll just I'll just give you the first three, then the rest you can look for them. So R is renal causes like polycystic kidney disease, and E is for endocrine, endocrine like primary hypothyroidism, and then pheochromocytoma. Then C is for coarctation of the aorta. Those are the This is the acronym for causes of secondary hypertension. So the rest you can just look at it at your own time. There. Okay. So also paradoxically, you can get goiter in hypothyroidism. We I know we always assume that goiter can happen in cases of hyperthyroidism, but it can also happen in cases of hypothyroidism. So in goiter, you usually have it in Hashimoto thyroiditis or atrophic thyroid. Okay, right. So now that we're done with the clinical features, we usually come to diagnostics. Now, you've seen the patient comes in, presents with these telltale signs of hypothyroidism. So what you next do as a physician is investigate. So, hello? Hi, sorry, issue with my internet and come back. Okay. Can you guys hear me now? Guys, can you hear me? I'm bado niko pabaya.
Yes, you can hear.
Okay. Okay. So as I was saying, when you're doing once your patient has come to you and then now you're over here wondering what's next, you are, as a physician, also a detective. In short, you're going to do diagnostics. You're going to investigate. You're going to find out what could have led to this. So the initial approach is to do your thyroid function tests, and that is most notably your TSH and your free T4. Can someone tell me, you can type in the chat, why T3 is not usually recommended in TFTs? You just type it in the chat as I continue. So there's a whole table. There's a whole table here, actually. Oh my, yeah, yeah. I built up to the question. I preempted the question when I was, yeah, okay. So TSH is elevated in primary hypothyroidism, but then it's also low in secondary and tertiary hypothyroidism. I'll explain that. So it's for that reason that free T4 is used as a confirmatory test for primary hypothyroidism if your TSH is elevated. Now, is there a reason why T3 is not used as a confirmatory test? So that one, I'll leave it to you to write in the chat. And I will go to the table. Now, this is the table. This is just a nice summary of why, of which organ is affected, and then the levels of TSH, T4, and then, okay. So euthyroidism is the normal guy, in which case they're all normal, which is represented by the straight line. Okay, now our main focus will be the hypothyroidism. So in primary hypothyroidism, the issue is with the thyroid, not with the others. So in this case, TSH will be elevated. It'll be seemingly elevated, as opposed to T4 and T3, which will be low. Yeah, so primary is for thyroid. So these ones are the ones being affected. So this is T3, T4 will be low. and TSH will be higher than usual. Then you come to secondary hypothyroidism, where the issue now is with the anterior pituitary gland, in which case TSH will be low because now this one has been affected, so TSH will be low. And then if this is affected, then definitely this is affected. So TSH will not activate the thyroid to produce the T3, T4, so definitely they'll also be low. All right. So now that we're done with primary and secondary, let's come to the subclinical. Now, the subclinical is the one that's not usually noticeable. By that, I mean your TSH will be high, but then your T3, T4 will just be normal. That's why it's called subclinical. It's not normally as obvious as the other forms of hypothyroidism. Okay. So tertiary hypothyroidism now has an issue with the hypothalamus. So this one is affected, which means that this TRH will be low or possibly even zero. And then if it's low, then your anterior pituitary gland is also affected, meaning that your TSH will be low as well. And then if this one is low, then definitely your thyroid is not activated to produce T3, T4. So if that one's affected, then your T3, T4 is obviously low, like really low. This is why tertiary hypothyroidism, all of them are extremely low, the other forms. Extremely low because this one affects the origin. Okay. Right. So now that we're in diagnostics, we're continuing on. You've done your thyroid function test. You've determined that your TSH and your T4 levels are what they are. Now now you're thinking, okay, could it be an autoimmune thyroid condition? So what do? We do a serum thyroid antibody test, which is where your thyroglobulin antibodies and your thyroid peroxidase antibodies come in. So if they're positive, these two are usually positive in cases of autoimmune hypothyroidism in the majority. So you can use this, or you can also use TSH receptor antibodies. This one is only detectable up to 20%. So usually we go for this a lot more times we go for thyroglobulin as opposed to TSH. But it's also a very important diagnostic tool. You can also do additional lab tests. Now, the additional lab tests would be your full blood count, in which case you'll find mild anemia. I'm sure you know why there would be mild anemia, because if you're a lady, you'll also have issues with your menstrual cycle. So that one's there. Then you'll also see your basic metabolic profile showing signs of hyponatremia, and rarely, in such a case, rarely hypoglycemia. So normally you'd find your sodium is the one that's low. Then in your lipid profile, you'd find your cholesterol levels are high, like really high. So you'd also have hyperlipidemia as well. Then in your creatinine kinase, you'd find that it's increased in cases of myopathy. Okay. So imaging isn't really that necessary, as in but you can still use thyroid ultrasound just to see if there is proper blood flow. You can also check for goiter and nodules using an ultrasound, which is also the case in hyperthyroidism. In You can also do a nuclear medicine thyroid scan, in which case you're looking for goiter and nodules. You don't really need to know the nitty-gritties of this, which is why I'm just going to leave it like that. If you want bonus marks, you can just say nuclear medicine thyroid scan. If someone asks you, how do you diagnose, how do you test for hypothyroidism? Once you've exhausted all of these, you've exhausted TFTs, then you've come to, oh yeah, and TFTs you do them separately. Like TFTs, You say we'd first investigate TSH levels, then we'd look at free T4 levels. If you have answers beyond that, then you come to the antibodies. And then now you move to additional lab tests like CBCs, your BNPs, your lipid profile, then creatine kinase, and then imaging. As a last step, because that's not really what we do in hypothyroidism. But you can just mention thyroid ultrasound and nuclear medicine thyroid scan, and you do. Okay. So treatment. Hypothyroidism is a very big condition, which is why treatment is lifelong. All right. The first line medication is levothyroxine. There's someone who mentioned that drug here. Yeah, thank you. Now you can see it here. The first line medication is that, a synthetic form of T4. Then you can also have liothyroxine, which is a synthetic form of T3. But that's used for myxedema coma, the complication which I will explain later on. And then take note that if you overdose someone on this drug, you can get signs of thyrotoxicosis or hyperthyroidism. So you have to be really careful with this, because uh, if you remember on etiology, I mentioned that you can get this condition from antithyroid medication, meaning that drugs that are used to treat hyperthyroidism, if they are overdone, they can give you hypothyroidism because they're meant to subdue the thyroid. Because the thyroid is hyperactive, now these drugs are meant to make it a bit normal. So if you do too much of these drugs, it will become underactive, and then you have hypothyroidism. Same case with this. If you're the drugs that you're given for hypothyroidism are meant to make your underactive thyroid a bit hyperactive to the point where it's normal. So, but if you go too far, you will get hyperthyroidism, meaning that your thyroid will be overly active than usual. So that's why you should be really careful not to overtreat the patient. So there are also drug interactions. Uh, This one, I think you've done it last year in third year. So there are drugs that reduce the absorption of this drug, levothyroxine. And they're usually PPIs like omeprazole, calcium salts, ferrous sulfate. There's the bile acid sequestrants. And then if your patient is on estrogen, you might have to increase your dose, because it will interfere. It will interfere with there'll be a drug interaction with estrogen. And then if you're also treating with androgens, you'd have to reduce the drug just by a bit. Okay. And if your patient is already on glucocorticosteroids, which interfere with thyroid hormone metabolism, you'd have to reduce the dose as well. So when you're giving someone levothyroxine, you also have to ask, are you on any contraception or are you on any steroid medication? You have to ask them that to know what kind of dose you're giving them. But yet again, this is just extra information. I'm not sure. Okay, maybe if you get the petty legs, they will ask you how this drug interacts with others. Like, no, actually, you might find someone. If you're in 7A and Dr. Kubo is asking you something, you might, yeah, she's there. You might be asked. Anyways, yeah. So now on complications. When we talk of complications, we mean that this condition has been here for a while, and now, apart from the clinical features, now you're getting something else that shouldn't have been. Okay, so when we talk now complications, we have myxedema coma. Myxedema coma is a potentially life-threatening complication. Let me tell you why. Because, okay, first of all, let's start with the triggers. The triggers are usually like infections, trauma, and then drugs. The drugs in this case would be like Lithium. Lithium is an anti-thyroid medication, by the way. So uh, lithium can cause, if you have lithium, it can cause this coma. So uh, what you'd present with in myxedema coma, you'd have impaired mental status, you'd have hypotension leading to shock and bradycardia, and then because of the shock, you'd have hypoventilation. Hypoventilation would result in hypercapnia, which is an increase in CO2 levels, and then hypoxemia, which is a decrease in oxygen levels. When that happens, now you start losing consciousness. And now that's the coma. It's a really rare complication. So it happens to like 1 in 100,000, I think. I'm not sure of the numbers, but it's really rare. It's extremely rare. Okay, but the other much more common complications. This would be primary thyroid lymphoma in patients with Hashimoto's, and then carpal tunnel syndrome. Again, carpal tunnel syndrome is a complication. Not many people know why. The pathophysiology is not known, but it is generally understood that if you have hypothyroidism, you're more likely to get. Remember what we said about your cholesterol levels being too high, and then you have hyperlipidemia. Yes. Now, another complication, your heart. You have increased cardiovascular risk due to this. So, there you have it. Those are the complications that we know of so far. And I think I would give you differentials right at this point. So, in your differentials, you'd have a non-thyroid illness syndrome. This is quite another long offshoots of hypothyroidism, which I would urge you guys to read on your own. I'm not going to go into it. Then you'd have adrenal insufficiency, and also you'd have congestive heart failure. Remember the stuff to do with I was telling you about dilated cardiomyopathy, which can lead to heart failure. The forms of heart failure here could be congestive heart failure. And then if you have congestive heart failure, that means there's an issue with your right ventricle. If you have an issue with your right ventricle, that means that you have causes of right ventricular failure. You'll just read on that. And then you'd also have pulmonary edema. Aside from bipedal edema, you'd also have, or peripheral edema, you'd also have pulmonary edema. Then sepsis and other systemic infections can give you something sort of like hypothyroidism. And also shock. This is why I'm going to urge you to read on causes of shock. This will be very important for you also in orthopedics. Please treat this as rather as important things to read. Then, lastly, because IMED deals with conditions like proper conditions, mm, not the psychiatric. Okay, siko baya, but these IMED lex, they look down on psychiatry as in. So they look at you at you say you have depression, and they'll be like, depression, depression, shida ya akili. Then yeah, it's kind of like that. Depression is also a differential because many of the symptoms of depression also align themselves with hypothyroidism. Same case with anxiety. Anxiety and hyperthyroidism are differentials because the tremors that you see in hyperthyroidism can also be seen in anxiety. The only difference is whether it is a fine tremor or a coarse tremor. That's the only issue. And then sweating is definitely there. Sweating in anxiety, sweating in hyperthyroidism. They're definitely all there. So you also, when you're dealing with thyroid, you also have to think, could it be psychiatric as well? That's why depression comes in. Okay, so we have an example of a history, in which case I would like someone to read. Let me see who. Yes. Faith. I guess Faith can read for us the biodata and the PC.
Okay, so I'm presenting Rachel Canini, who's 30 years old resides in Kikuyu and works as a secretary. She's married with two and has two children. She was admitted 3 days ago and came in presenting fatigue for 6 months, weight gain for 3 months, and hair loss for 2 months.
Thank you. Now, could Thomas read first? The left half of the HPI. Bet Thomas.
Yes. The left half from in addition.
Yeah, until the midsection.
In addition to her fatigue and weight gain, Miss Kanini has noticed that her hair has been falling out excessively over the past 2 months.
Hi, sorry to disrupt you, but you'll start from here.
Oh,
Yeah. Then you come here.
Miss Kanini, a 30-year-old secretary from Kikuyu, presents to KNH 3 days ago with a 6-month history of fatigue, which she describes as feeling tired and sluggish all the time. She knows that she wakes up every morning feeling unrefreshed and that her energy levels remain low throughout the day. She has tried to compensate by taking more breaks at work and sleeping in later on weekends, but this has not improved her symptoms. Over the past 3 months, Ms. Kanini has also noticed that she has gained 5 kg in weight despite no changes in her diet or exercise routine. She said to cut back on carbohydrates and sweets, but has found it difficult to resist her cravings. She has also noticed that her clothes are feeling tighter, particularly around her midsection.
Thank you. Let's see. Could Sadia read for us the other half?
Okay, in addition to her fatigue and weight gain, Ms. Kanini has noticed that her hair has been falling out excessively over the past 2 months. She reports that she loses a significant amount of hair every time she washes it, and that her hairbrush is often filled with hair after brushing. She has tried using different shampoos and conditioners, but has not improved her symptoms. When questioned further, Ms. Kanini denies any history of heat intolerance, palpitations, or tremors, which makes hypothyroidism less likely. She also denies any history of fever, night sweats, or weight loss, which makes infection or malignancies less likely.
Thank you. Now, let's see. Khalid, could you read first the left half?
Okay, Miss Kanini reports that her menstrual cycles have become heavier and more frequent over the past few months, which could be related to her hypothyroidism. She denies any history of galactorrhea or amenorrhea, which makes pituitary disorders less likely. On further questioning, Miss Kanini reports that she has been experiencing constipation, which she defines as having fewer than 3 bowel movements per week. She denies any history of abdominal pain, nausea, or vomiting, which makes GI disorders less likely.
All right, thank you. Let's see. Who haven't I asked to read? Debbie can finish off. Debbie Onsongo.
Sorry, I was on transit home, but let me read. Okay. So Miss Kanini also reports that she has been experiencing dry, rough skin, particularly on her hands and feet. She denies any history of skin rashes, itching, or lesions, which makes skin disorders less likely. Ms. Kanini denies any history of muscle weakness, cramps, or stiffness, which makes muscle disorders less likely. She also denies any history of cognitive impairment, memory loss, or mood changes, which makes neurological disorders less likely.
Thank you. Now let's see. This one, I think we can finish off with Mark. Mark, Kasal Mark, you'll just read the entire page, Sasa.
Yes, he reports a family of hypothyroidism from the mother, as well as sedentary lifestyle. Works as a secretary and has physical activities. Reports having a poor diet, high carbohydrate and sugar intake, and she complains of stress. Reports a moderate level of stress at work. Since admission at KNH, lab tests were done, and she was soon started on levothyroxine daily with close monitoring. Ms. Kanini is currently stable and is being monitored closely for any signs of improvement or worsening of her symptoms. She is tolerating her medication well and has not reported any adverse effects.
Thank you. Thank you guys for reading the HPI. There is still more. I'll just ask Grace Makioto to read the past medical history.
Okay. For her past medical history, she has had no previous hospitalizations or surgeries, no known food or drug allergies, no history of TB, hypertension, or any signs related to the Jones criteria, no epilepsy, no asthma, and no history of diabetes mellitus. She has a negative RVD status. For her family history, her mother has a history of hypothyroidism. There is no other significant family medical history. For her social history, she lives with her husband and 2 children in Kikuyu, works as a secretary in a busy office in Karen. She reports a moderate level of stress at work, no history of smoking or alcohol abuse, and denies any history of trauma or abuse.
Thank you. Let's see, who hasn't read yet? Joy, I think you can read for us. Joy? Okay. Doesn't seem like she's around. I guess then I could ask Khalid. Khalid, could you read for us review of systems and just wind up with a summary as well?
Okay, so review of systems, general, fatigue and weight gain. On skin, there was hair loss and dry skin. GI, there was constipation. Endocrine, there was menstrual irregularities. Neurological, there was no symptoms. For summary, Ms. Kanini, a 30-year-old married secretary from Kikuyu, presents with a 6-month history of fatigue, 3-month history of weight gain, and a 2-month history of hair loss, with risk factors including a family history of hypothyroidism, sedentary lifestyle, a poor diet, and stress. She is currently stable on levothyroxine daily with regular monitoring of her symptoms and lab results.
Thank you. So, from this history, what can you tell me? This now is an open forum. What can you tell me from this history? What you've just read?
For me, from this history, I can say that the patient is suffering from hypothyroidism because the symptoms they are similar to those of a patient suffering from hypothyroidism.
And what complications would you expect her to get? Keep in mind that I'm going to give you a hint. She's a secretary. What complication do you
Yes.
think she's more likely to get?
Yes, I think carpal tunnel syndrome.
Okay.
Yes. And can we say cardiovascular risk? Um, like because she does not move so much.
Yes, that's also true. Yeah. Those are the
Yeah.
complications she's more likely to get. Now, based on now we're just gonna go back here. In between families, in between past medical and family social, is there anything that might have been left out that's important to us? I left it out on purpose just to ask.
OBGYN history.
Yes, thank you. PGY history, the obs gain history is also very important. Why do you think it's important?
I think because when you're taking us through for hypothyroidism, we noted that in the signs and symptoms, it would affect the female cycle to some extent. So
Yes, thank you. Nice. Okay. Anything else? Now I've written here, ask a bit more on the family. Now, what do you think should have been asked? Now this is just general family history. What should have been asked in the family history?
The health of our children.
Anything else? Once I come to think of it, health of children, but do we know anything about the children? No, we do not. So, we also need to ask. She has two children, yeah. But then we don't know how old they are. We don't know whether they are well, as he mentioned, health. We don't know whether it's a boy or a girl or two girls or two boys. We don't know. So again, ask a bit more on the family. Also, when you're asking about family history, uh, also usually we start with the family that she came into the world through, as in these are her parents, her siblings. We normally ask this a lot. So when you're starting with family history, you say she was born into a family of two parents and two siblings, of which she was the firstborn. Kitu kaa hiyo. You just say both parents are alive and well. Then you go into the relevant family medical history, like if the mother has a history of hypothyroidism. Then, if the father or if one of the parents is deceased, then you just say the parent died a certain number of years ago at this age. You have to mention the age at which parents died, and then the cause. You could say due to complications of diabetes, due to complications of the heart, or due to unknown causes. Because sometimes the patient might not. So due to unknown causes, that's also a valid statement. Then I think from there now you just start saying you go to the siblings like she is the firstborn in a household of five siblings, namely two brothers, three sisters. Then after that, once you've closed that chapter, then you go into the family she married into, or if the patient is a man, the family that he is the household head of. Yeah. Then you start talking about his wife and the kids, or if it's the lady, you talk about her husband and the kids. Yeah, something like that. So ask a bit more on the family. And also in social history, is there anything that might have been left out? There's a reason I'm focusing a lot on family social history. Is there anything I might have left out in social?
How is she paying for medication and treatment?
Okay, nice. Yes, that exactly. Anything else? I can leave it at that. So, why do you think I said ask about housing conditions? In particular, why did I ask about housing conditions really in hypothyroidism? I mean, it's not RESP, where definitely housing conditions would play a factor in whether or not you have pneumonia or TB. So why did I write ask about housing conditions? Quick question.
Are you
Mhm.
seeing the possibility of toxin in the
Toxin.
house?
That's nice. Yeah. Which toxin?
Iodine,
Mm-hmm.
radiation iodine. Yes.
But wouldn't radioactive iodine be a hospital thing? Uh, uh, Allow me to take you to this clinical feature that has been mentioned before. Do you guys remember something called cold intolerance? Can someone tell me what cold intolerance is?
It's when somebody is overly sensitive to cold.
Now, tell me this. Is Kikuyu, okay, how many of you have been to Kikuyu? Is it normally a hot place, cold place? Sana sana, what do you think? Those who live around Kikuyu or who
It's
know
very cold.
cold. Now, in such a patient who has cold intolerance, what do you think she'd always feel in that house? Wouldn't you say that in the mornings, especially in the mornings, because around Kikuyu in the morning there's a lot of cold. So and she has to go to Karen. And presumably as a secretary, she wakes up early in the morning to get before her boss so that she opens the office and then gets in and then settles down so that the boss can come. So and then to add on to that, maybe she uses a matatu. So let's say that and then the distance from Kikuyu to Karen it's not a lot, but it can be also prone to jam, especially if she's passed or along the path to Langata, those sides of Karen heading to Langata. There's a lot of jam along those sides. So that means that she has to get up early, go to Karen, get a and then from Karen, get a mat to her workplace, and then I'll open the office early, and then all that. In all that time, what if it's cold? And then moderate level of stress. Maybe she's being kept in the office until late, like instead of the usual 5, maybe she's being kept until 7. And then, of course, it's cold. And now she's coming back home where it's cold. So definitely, when you're asking about housing conditions, you have to ask, does she feel the house is a bit warm? Is it cold? Is it maybe it's an aggravating factor to her because now she's saying the house is too cold. She has to use blankets. Like, are you guys seeing the thought process there? Ama nimefanya I've lost you somewhere. But don't worry, these things take time. Like it doesn't come like this. It can take time. And especially if you're in the endo ward for your end of rotation, you just have to probe deeper into the family social history because uh they they expose a bit more of what could be under an underlying issue there, or what you could have missed in the HPI in the family social could come up. Like, what if you forgot to ask about the family history? Then, when you're asking about family social, then you're being told, oh, by the way, my mama alikuwa na hii issue. Then you bring it up in the history. See, like it comes with time. So don't stress. Don't stress if it's taking a lot of time for you to get this. Now, now, uh, I'm going to like describe this. So when you're doing your HPI, you mention the how it started, like the symptoms. You describe the symptom one by one, how she wakes up. As you can see, the fatigue, how she wakes up feeling unrefreshed, try to compensate, sleeping in later, then the weight gain, and then the hair falling out, and then any ruling in. Now here is when you start ruling in, ruling out. And then, of course, reporting menstrual cycle has become heavier and more frequent.
Excuse me, David.
Yeah.
I have a question on the previous slide.
Oh, go
on. Okay, I was just wondering, as you're describing the fatigue and the others, is that considered journaling, or it's okay to do it as it has been done?
As the way this is.
Yeah.
Okay.
Like the fact, for example, she's trying to resist her cravings. She's trying to compensate by taking more breaks and all that.
Now, it depends with the leg that you face. For someone like Dr. Ilovi, it's very critical that you mention even this minor details that yes, the patient has been doing this, but then this has happened. But then for someone like Prof. Amayo, he wants straight to the point histories. So it just like they don't sorry for the crude language, but they don't give a shit. They will say, okay, so you gained weight. Okay, fine. Then they will tell you, despite no changes, okay, that's fair. She has tried to cut back. They will say, this one is not important. Difficult to resist a craving is not important. What they will ask you is, has she noticed that her clothes are feeling tighter? Yes. So they will say, remove that, stick with this. For someone like Dr. Ilovi, they'll be like, okay, fine. So you said that there have been no changes in her diet or exercise. From what? From where? What has she been eating? What has she been doing? So that you can say despite no changes. It just depends on the leg.
Oh, okay, thank you.
Yeah. I know it's not a really good answer, and I'm sorry for that, but very subjective. This unit is very subjective. And I will use those two because I've interacted with them. Samayo likes things straight to the point, so doesn't want a lot of details as long as you get to the core of the matter, as in 6-month history of fatigue, describes the feeling tired and sluggish all the time, wakes up every morning like this, nini. Try to compensate, not really important. Nasonga, naenda kwa weight gain. Despite no changes in diet or exercise routine, she has noticed that her clothes are feeling tighter, particularly around her midsection. Then you mentioned if she needed to change the holes in her belt. Unasonga. Then, in addition to that, hair has been falling out excessively. Using this she has locked a significant amount of hair every time. Her brush is always filled with hair. Tried using, that's okay, fine. But then, when you say menstrual cycles have been heavier and more frequent. Now, for someone like Dr. Ilovi, they'd ask you, okay, what do you define as more frequent? Number of pads. Okay, fine. How have the number of pads increased since? Like she was previously using this number of pads. Have they increased since then? You'd be asked all of this. Then, for someone like now, and then you'd be asked heavier. What do you mean by heavier? Like, uh, describe the blood flow. Was it in spots? Ama now it's fresh blood. You'd be asked something like that. So when you say journaling, do you mean like extra information? Ama because it also has to be relevant to the cause. Hi. Uh-huh. Oh yeah, I wasn't gonna do much on Gen exam. Oh yeah, review of systems. Now another thing I need to ask, is there anything here that you think should have been mentioned? In your review of systems? Anything that you think should have been mentioned?
Can I say genitourinary?
Yes, thank you. Genitourinary. Yes, nice. Anything else? This review of systems is very focused. And what they need from you is a lot of knows everything. So, in short, also when you ask me about something like constipation, JT, you also have to say no nausea, no vomiting, no diarrhea, no this, no that, no that, no that. There was constipation, but yeah. Same thing for endocrine. When you say menstrual irregularities, mention, like you just mention them. And then no symptoms. You don't say no symptoms. You say no headache, no seizures, no changes in visual, gustatory, auditory, olfactory, uh, organs, sensations, and then you proceed. Like for review of systems, just mention each thing. I've just shortened it so that it fits, but usually that shouldn't be the case. You just say no nausea, no vomiting, no diarrhea, there was constipation, no abdominal distension, changes in bowel frequency, no, like that. You just say that, all of those. Okay. And then your summary, once again, it should be strictly two statements. I would want to tell you two statements where you focus on the important negatives and the important negatives. The important positives in this case would be stuff like risk factors like family history, sedentary lifestyle, poor diet, and stress. And then you also mentioned how they are currently doing. Currently stable on levothyroxine daily with regular monitoring. So the summary should have your biodata and your presenting complaint, as well as important negatives and positives, and then the current progression. Yeah, all that in two statements. That's your summary. Now, here we are with the case history. Oh, Lord, this one. Hey.
David, sorry,
Yes.
I have another question.
Oh, yeah, go ahead.
For the review of systems, I think it was either you or someone else was tutoring us, and they told us we shouldn't review a system we've already reviewed in the HPI
Oh,
again.
yeah. Mm.
So I thought most of the systems here you had already mentioned in the HPI.
Oh yeah, that's actually on me. The ones that haven't been mentioned were the GUT mostly. GUT and a bit of CVS because CVS we didn't exhaustively cover. There was something about palpitations, but then from there nothing. So also CVS should have been mentioned. Yeah, that's actually on me. Thank you for that.
Okay, thank you.
All right. So we're on our case history. This is just a question to see if you guys recall what we've just covered. So I'm just gonna read this, and then we'll do the following questions. There are 8. They're just 8 in total. Okay, so a 55-year-old woman presents to the clinic with a 6-month history of gradual onset of cold intolerance, muscle weakness, and constipation. She also reports a decrease in her appetite and a 20 kilogram weight gain over the past few months. Her physical examination reveals dry, coarse skin, hair loss, particularly on the lateral aspects of her eyebrows, puffy hands and face, slow speech and movements, a slow heart rate of 50 beats per minute, a blood pressure of 120 over 80 millimeters of mercury. Her lab results show a TSH of 20 units. The normal range is 0.4 to 4.0. The free T4 levels would be 0.3, in which the normal range is 0.8 to 1.8. The free T3 levels are 0.2, in which case the normal range is 2.3 to 4.2. Just from this, what picture comes into your mind?
Primary hypothyroidism.
Okay. Tell us why based on, okay, so we can agree it's hypothyroidism. Now, how is it, now from this, do you think it's primary, secondary, or tertiary?
Primary.
Okay, you can explain that.
Because you can see the free T3 and T4 are reduced and there's a compensatory increase in the TSH.
Nice. Okay. So you've actually answered number 1. Thank you. So now number 2. What are the symptoms that made you consider that diagnosis? Just from here, the symptoms that you can verify. This one I will ask Debbie. The symptoms that have led you to verify this as primary hypothyroidism. What are the symptoms that you can see that would make you think it's hypothyroidism? If Debbie isn't near the mic, then can anyone else explain? Keep in mind that symptoms is what the patient tells you, and signs is what you as a doctor can see. So, what symptoms would tell you that this is hypothyroidism? Thomas, I can see you've unmuted.
Weight gain,
Uh-huh.
cold intolerance,
Yeah.
and loss of hair.
Loss of hair. Okay. And so usually when you say symptoms, is it that, has this patient told you that she has had weight loss, ama it's something that you've seen?
She has
Based on
told
this.
me.
Based on this.
It's something that the patient has told you.
Because hair loss was on the physical examination, which is a sign as opposed to a symptom. So the sign is what you as the doctor can see, whereas the symptom is what the patient tells you they're suffering from. Like
So
what
what
they
if the patient comes as a bald patient because she saw that she was losing hair and then shaved?
That's an interesting one. Okay, so in that case, maybe she shaved. You don't know. Maybe she shaved voluntary. Yeah. So you have to wait for her to tell you that, oh, by the yeah, pia nilipoteza nywele before now you can say that's a symptom. Yeah. So in this case, the symptoms that would lead you to think this is hypothyroidism would be what she reports. So the cold intolerance, the muscle weakness, the constipation, also the decrease in appetite and the weight gain. Those are what she's telling you that she has uncovered. And then you as the doctor will uncover that this is her what you can see. But also other things, yeah. So signs and symptoms are very people normally mix them up. Also in clinical features, it will be signs and symptoms. So it's mainly it's the difference is who is who's doing the observation. Symptoms for patient, signs for the doc. But then so generally we've answered 2 and 3 actually. But now also number 4, Grace already did number 4. So I guess we can do number 5 because she went for the lab data like TSH levels, T4, T3 now. Oh yeah. Is there anything else that might show us hypothyroidism apart from the TSH and the T4 and T3 levels? Anything else? Any other lab diagnostic tool that can be used?
We talked of the blood count.
Mm-hmm.
We see a mild anemia. There was also hyponatremia.
Mm-hmm.
Yeah, those are the ones I can clearly remember.
Yeah. The hyponatremia in your BMP, okay. And what about your lipid profile? How would that show typically in a hypothyroidism patient, in a patient with hypothyroidism? How would your lipid profile look like?
Hypercholesterolemia.
Yes. And if you're assuming your patient has an autoimmune thyroid condition, what would you go for?
Thyroglobulin antibodies.
Yes. Okay. And there's also the peroxidase antibodies. Okay. And now there's also this other thing. Because normally when you do investigations, there's the lab works, there's the microbiology lab, there's the microbiology aspect, then there's imaging. We don't have microbiology in hypothyroidism, so we go for imaging. Now, imaging is not really necessary, but if you are pushed to the wall, to say you've exhausted everything in labs and then now you don't have micro, and then now you're in imaging, what would you say?
Thyroid ultrasound.
That's one.
I can't remember the last one. I just need for nodules and goiter.
Yeah, that one. So the other one would also be a nuclear medicine thyroid scan. So if you really push to the wall, because thyroid imaging isn't really used as a diagnostic tool. The ones that are used here are their TSH and then your free T4. Those ones are the ones that are most commonly used. But if you're really pushed to the wall, then you can say that. So let's move on. This one, okay. I see time is going. So I'll just ask. We've already covered number 7. Number 5, I will leave that to you to think about. Same for number 6. Number 5 and 6, I will leave that to you. So treatment option. We already talked about first line treatment. So can anyone tell me first line treatment of hypothyroidism? First line treatment. Let's see. Who hasn't talked in a while? Sadia. Yes, thank you, Debbie. It's levothyroxine. Yeah, that's usually the first line treatment. So, treatment option is the pharmacological aspect, and then there's a supportive care. So, supportive care is stuff like managing her pain if there's any pain, and then probably giving her something, she has a puffy face and hands, so that's a lot of fluid. So now you have to drain the fluid. How do you drain the fluid? You give a thiazide usually. Thiazides are very important for edemas. Yeah, but usually that's how it is. And I think we'll be done. I'll send the slides, or are you guys on the drive? If you have access to the drive, that's easier because I'll just post it there, and then now you can go through these questions and the slides at your own time. Remember not to make them your main slides or source of information, as there's so much more that I haven't mentioned that will come up later on. So all in all, I guess, okay, tomorrow we're meant to cover, okay, today we were meant to cover hyper and hypo, but we only covered hypo. So I guess we can just do history on Fridays. Tomorrow will be history day. So if you guys have histories, we'll listen to them tomorrow. Do you do anything for the weight gain? Usually, okay, for the weight gain, you tell them, okay, usually let the drug do its work and also add lifestyle modifications. When I say lifestyle modifications, I mean those things that you are being told that you walk more, do this, do more exercises, stuff like that. As for the hair loss, I'm not sure. The hair loss is a very tricky concept, if I'm being honest. Yeah. So once again, thank you guys so much for coming. Tomorrow will be an interesting session on history taking, where I hope you guys are ready to present your histories, which we will all critique and give guidance on. If there's anything like how you guys have mentioned stuff that I have missed, either intentionally or unintentionally, that's the way that tomorrow will be like. We'll review all our histories together. So, okay. So, hope to see you tomorrow, same time, same link. Yeah. And as always, have a good night.
Thank you.